วัสดีค่ะทุกคน Hello everybody. It's only 16 participants now. Not good. Let's wait one moment because Dr. McQueen joined a incorrect link. So I start to tell him to join this link now, pretty soon. Are you stay together?
From me, no. Una and Kwan is together.
Okay.
Hi, Serena. Can you hear me okay?
Okay, Dr. McQueen. Hello.
I cannot hear you. Let me see what's
Really?
wrong here.
Oh, no. Hello, hello.
Oh, I think I know. Just a moment. There. Can you hear me now?
Yes, loud and clear.
And I can. Wonderful. I can hear you.
Okay.
My speaker was turned off. Good. So this is our group. Excellent.
Yes, and welcome back, Dr. McQueen, for today's meeting. I'm really happy that you can join us now.
Me too.
Okay.
It's a pleasure. It was last October. It's been a long time. Let me start the lecture here so I can share it. Let's see if this shares. Are you ready? Tell me if this comes through.
Okay, you can start it now.
Mm-hmm. Do you see it?
Yes, doctor.
Fantastic. Well, it is wonderful to be back in Contain, even though only virtually. And today we're going to talk about amblyopia. So this is my Thai nickname that was given me many years ago by Dr. Pataya. This is last year's group, so I know the group is this year is different, but there may be some of the same at KKU. And I just wanted to point out our 4 outstanding Thai fellows. We have one French woman in here who's our optometrist with Serenia, but these are the 4 people we've had over the last couple of decades. Please send more. We love you guys. So we've had many wonderful experiences together. This is Dr. Terry O'Brien, who I'll mention again in a minute. This is us having fun. We work very hard. Lunch is quick, and occasionally other people will grow mustaches. This was our goodbye celebration, which we do for all of our fellows. And this is us being taught to why we're not too good, but not too bad. And I would just like to put a plug in. If anyone attending a lecture today or knows of anyone who's interested in pursuing an international research fellowship, much as our former fellows did, please contact us. For anterior segment, contact Terry O'Brien. This is his email here. Here he is. And me, if it's pediatrics, or my colleague, Galdeka Pro. So let's carry on with the lecture. There will be some overlap, and I'll explain that in a minute. That's by necessity. So these are the steps we'd like to get through today if we have time, and I think we will. And particularly important is the amblyopia treatment studies, item number 6, and what's new in amblyopia is interesting and fun. So by necessity, since I talked to you about visual development last October, this time we'll overlap a little bit, but we're going to go completely a different or new direction, applying those principles to amblyopia. So amblyopia comes from Greek, and its literal meaning is dullness of vision. I'm going to just try to change my display here for a second. That's better. And amblyopia, as defined by Van Noorden, this has been modified slightly, but this is a good definition. It's a decrease in visual acuity, usually in one eye, occasionally both eyes, that persists after the correction of refractive error or removal of any pathologic obstacle of vision is accomplished. That would be cataract removal, and we have no other organic causes for the reduction in vision. That's a pretty good definition. So amblyopia actually represents abnormal development of the visual portion of the brain. And I told a mother this a couple of years ago, and a year later, she was back for routine follow-up. And she said, I've been worried all year that my child has a bad brain. And I said, oh, no, it's just the visual part. So I've modified the way I phrase this, but it truly is something that occurs predominantly in the brain. So synapses in our visual system really occur in three areas. One is the retina, two is the lateral geniculate, and three is the primary visual cortex. So things that cause amblyopia tend to be abnormalities that affect our binocular interaction or degradation of well-formed images. And that would include cataracts, refractive error that's asymmetric or significant, and of course, strabismus. So amblyopia can also occur in conjunction with organic disorders that also degrade the quality of afferent visual information. So for example, a macular scar in a baby will also lead to amblyopia. So presumably, if you could fix the macula, a few years later, the visual acuity might not be as good as we would expect in an adult. It probably wouldn't be. So how common is amblyopia? Well, it will be different in Thailand, but in our country, it's about 2% of the population. Most studies have shown somewhere between 1 and 4%. Certain subpopulations, such as our indigenous people, have a higher rate of astigmatism and high refractive error. And amblyopia, of course, overlaps with strabismus. Amblyopia is the most, I believe, still common cause of unilateral visual loss in individuals younger than 45. These are all the basic principles. This is a very old picture. You can tell by the dress in Dr. Marshall Parks' office of 3 kids in the same family that have amblyopia, 2 on one side, 1 on the other. So if we're seeing this child for amblyopia, and they are known to have younger siblings, particularly in the amblyogenic age group, which we'll discuss, you do want to check the siblings. So let's go to a little bit of basic science. This was where it overlaps, and this will be actually clinical first, but basic science accompanying it. So this is a view of a lily pad, very pretty pond with flowers. And let's look at our components of vision. There are 4 I've listed here, and there are others besides this. So we have central vision, peripheral vision, both for movement as the wind blows a little bit or the waves move the lily pad, and form. Certainly color perception, and for us, binocular vision, and there are other components as well. And they all mature in a carefully orchestrated series of steps. And when something goes wrong at an early step, things go wrong at a later step, perhaps worse. So it's central vision, though, with amblyopia, we're primarily worried about. Now, abnormalities found in amblyopia. There is an English slang term for people that like to lump things together. They're called lumpers. I listed it at the bottom. So this is what you would do if you're a lumper. You just say, oh, amblyopia, decline in central vision. But there's more to the story. So if we go to another group of people that are called splitters, those who like to divide things into subtypes, which are probably most ophthalmologists, it's not only decreased visual acuity, but it affects contrast sensitivity, contour interaction, brightness perception, may cause suppression in the amblyopic eye. There are defects in form and motion processing. That may be important with driving and other things. Eccentric fixation is possible. And a small number, maybe about 10%, have a pupillary defect that's afferent. So the hallmark of amblyopia is therefore decreased foveal visual acuity. Now, usually amblyopia is clinically defined as a difference of 2 or more lines. So that will make a big difference on how your chart is designed. So for example, between 2020 and 2025 and 2030, there is a 2-line difference. So we might treat for amblyopia if one eye is 2030 and the other eye is 2025, but this is not a linear scale. So 2 lines difference at one point may be different than 2 lines different at another, but nevertheless, that works pretty well for us as clinicians. The visual acuity has been noted for many years as lower typically when you present a full line than if you present one letter at a time. And that's called the crowding phenomenon. We're going to look at that in a moment. And it may become more pronounced as you treat the child for amblyopia. So if you start with 2200 vision and you're now down to 2080 with a significant improvement, the crowding phenomenon may be more apparent at 2080 than it is at 2100 or 2200. So these are 3 charts all designed differently. This is a common chart using just HOTV, but it could be any number of objects, but this has non-proportional spacing. This will tend not to show crowding as much as the proportional spacing shown here. This is full line. These are isolated letters, but these little bars called crowding bars create the same effect as this proportional spacing. So this is an old grid illusion from the 1800s, and it's called the Hermann grid illusion. And I'm going to get my pointer turned on here. And so if you foveate where my dot is, and I move my dot away, you'll see that that intersection probably is very clear, but all of the other intersections have a little gray patch. If you foveate up here, then the other ones will all have a gray patch, and this one will not. So this is Ludmar Hermann, who developed this, and he was a German physiologist. Herring, sometime shortly later, noticed that you could get a similar illusory effect if you did a black grid and white squares, and they sometimes call it the Hermann-Herring illusion. But when we're in the office testing children, there are many, many problems. I'm going to run through these slides quickly, but they're interesting and sort of fun. So we have kids who malinger to try to obtain glasses. In other words, they pretend like something's wrong. We have reverse malingering, where they have peeking and memorization and guessing. And cooperation can be a problem, as I will stage for you here in a moment. This was my neighbor when I lived in Boston. So this is a little girl peeking. The solution is put on a patch. Cooperation can begin to be trouble. This is very rude. Things can get rough, rougher still, and finally totally out of control. And I did this to have a good picture, but please don't do this too often because it takes hours to put it back together. But a good picture. There's another thing that's in your books, which talks about the effect of reducing the illumination in amblyopia. And this was always confusing to me as a resident. So it's the so-called resistance to reduced illumination. The threshold for perception of light is fundamentally normal in amblyopic eyes. So the visual acuity in amblyopic eyes starts low, but it again approaches a normal curve. And I'm going to show you this graphically because this will make it, I think, all make sense. So the vertical axis is visual acuity here. The horizontal axis is illumination. If we take you or I and we begin to keep the same letters on the wall, but we start to turn down the illumination in the room, and this is not a computer monitor, but rather an old standard style chart, the visual acuity will begin to decline in all of us and kind of follow this curve down here. So now if we take one of our amblyopic patients, they start out much lower than this curve. This is the amblyopic visual acuity. And this is the green showing where it is. But it continues at about the same level of visual acuity until it gets to the normal curve. Then it follows the curve down. Now, clinically in the office, that's hard to measure. But what is interesting, if you then go to the other clinic and see some diabetic patients or someone with CME, they will start out low, similar to the amblyope, we'll say, but their visual acuity doesn't go to the normal curve. It starts to drop off almost immediately as you reduce illumination, following a different curve. Thus, this is the so-called reduced illumination, resistance to reduced illumination. So this always worries me, but occasionally around 10, maybe 15% of amblyopes will reportedly have afferent pupils. In my practice, it's lower. I always worry when there's an afferent pupil that I may be missing something. And for example, I may be calling the glioma amblyopia if I don't know that the glioma is there. So we mentioned a few minutes ago, visual development. Components mature at different rates during childhood. So as you know, if you have younger brothers or sisters or children, compared to adults, newborn infants have poor vision, poor color, poor binocular vision. And this is a curve that we're going to come back to again in a few minutes. So on this curve, again, age is a horizontal axis and visual acuity is a vertical axis. And it's measured in units you and I are not familiar with, but particularly from day-to-day work in cycles per degree. So you and I would see up here at 30 cycles per degree, but notice the curve starts out with very poor vision. There is right at birth, 12 months, 24 months, 36 months of age. So you can see by the curve that The acuity starts out very poor, rapidly improves for about 6 months, but then very slowly improves over the next 2.5 years, so that most normal kids reach adult levels of vision by about 3 years of age. And this is a curve from the teller acuity charts. I don't know if you use those in Concave, but we like them here, but not everyone does. And I showed you this last time, but it's important. Here is the picture. This is what the adults would see way over in here, and a little graph is shown here. And here we are at birth, way at this point here. You can barely tell there's humans there. Plus, notice the colors are washed out. This was an attempt by the Vida Teller to put together a set of slides mimicking what shows up on preferential looking. So here the baby is now 6 weeks old, a little better, 3 months old, 4 months old, and 6 months old. So now we're at this steep part of the curve, and then we're going to leap all the way forward, and here's what you and I would see. So that's what approximates the developmental curve of a normal infant without amblyopia. So this is not going to work very well in this baby, but this does. So here there's Kermit the Frog, and here are the teller acuity cards. Again, we like to use these, but I will tell you, if the findings on teller acuity cards disagree with my clinical findings, I will usually go with the clinical findings, and most people will tell you that. However, if they agree, then I kind of breathe a sigh of relief and say, good, things are in order. When they disagree, I tend to look at the patient more carefully, thinking something is wrong, either my clinical impression or the teller acuity. This is what you see. This is being done vertically. And notice, you can tell that the little girl looks up when the stripes are up, down when the stripes are down. And by making the stripes more and more narrow, it's harder to see them. And finally, the child will look randomly. And this is called forced choice preferential looking, or commonly known as teller acuity. The forced choice, the person who's forced to choose, is this person back here, not the baby. And there's a little peek hole here. We usually look over the cards and normally use them horizontally. So let's go back to this developmental curve. So it is normal to be 2200 or 3 cycles per degree at 18 months of age if you're a young child. And you may start out with vision in roughly the 22,000 to 2,600 range. So this is a remarkable change. It wasn't too many decades ago that this work was done at MIT in Dr. Hell's lab. And this is a fairly old paper, but it shows something that clinically I think is very important. And that is, we have the critical period, which is what I just showed you. That's the period where we go from bad vision to good vision. I'm going to just set one thing on my phone so I can watch the time. I'm going to turn away for just a moment. There we go. And then there's the sensitive period. This is the period during which amblyopia can develop, and that's roughly 6 or 7 years of age, sometimes a bit longer. So if you have a severe injury to your eye at age 9, it's not likely you're going to get amblyopia as a result of it. If you have a corneal laceration at 2, you may save the eye, but the visual acuity may turn out very poorly. And then there's a so-called reversal period. This is a period during which you and I could potentially treat the patient. I was taught, as most of us were, that it's roughly the first 9 or 10 years of life. But that turned out to be wrong. It is considerably longer. In fact, we know that it extends to 18 years and probably remains so throughout life, but to a lesser degree. Now we're going to look at pathophysiology. So the action is going to be in the geniculate and the striate for what we're doing here. So let's talk about the retina just briefly. Traditionally, it's been thought there are no changes in the retina in amblyopia. However, there's papers showing some changes that may be a little more subtle, particularly thickening of the choroid on OCTs, and there may be other changes as well. So the jury is still out, so to speak. There may be things occurring in the retina, but for most of our discussion, we're going to concentrate on somewhere else. So this is the left eye. This is the right eye. This is a corresponding retinal point. We'll say that the fovea is directed here, but this is a point being stimulated on the retina. We'll say 3 millimeters temporal to the fovea in both the right and left eye. This visual information is 4.5 centimeters in a young child, 9-year-old, 6.5, and most of us as adults are thereabouts. The information travels, of course, in the optic nerve and then goes to the labrogeniculate body. But notice at the decussation here, when it arrives at the labrogeniculate body, visual information that is split apart in real life by about 4.5 or 6.5 centimeters as an adult is stacked on top of each other in columns adjacent at the geniculate level. So there's a lot of processing that's beginning to occur. This is another drawing of the geniculate. Now, it turns out that the geniculate in primates is 6 layers. The bottom 2 are bigger cells, so they're called magnocellular, and the upper 4 here are called parvocellular because they're small. We're going to go on with that in just a minute. So these are the 2 magnocellular layers, big cells, small cells, 4 up here. So a total of 6. Now there's also something else that I know relatively little about, but it's called coniocellular layers or coniocytes, meaning dust. These are little layers between the other layers, and they may contribute to brightness and contrast sensitivity, and they may have some influence on eye movement signals. What's interesting is we can take an amblyopic primate, human or monkey, and we can see changes by light microscopy. Now, these are the 6 layers on one labrogeniculate. 1, 2, 3, 4, 5, and 6. Notice that 6 is quite different from 5. In fact, if we look at the other labrogeniculate, see what's happening here. The cells are pretty well preserved. These are fewer in number or smaller, and there's a difference. So you can begin to find each eye goes to 3 layers. So the right eye will go to 1 magnocellular layer, 2 parvocellular layers. The left eye or the opposite eye will go to the other layers. And I've listed them here, and I can never remember exactly what they are. And for us clinically, that may not be important, but the concept is important of 1 magnocellular, 2 parvocellular layers for each eye in each labrogeniculate body. Now, let's return to the Hermann grid illusion. So if you take one of your or my amblyopic patients and show them the grid illusion, something different may happen. So in a normal receptive field, the receptive fields are smaller in the normal foveal area and larger in the periphery. And notice the size of this little receptive field falls well within the boundaries of where the black boxes would be. But this one overlaps, which means the black of the squares may have some influence on your perception of the center of this circular receptive field. And there are multiple receptive fields overlapping, and there are color ones and all sorts of types. So this is what probably happens. We're back to our real visual, our real Hermann grid illusion. And here's an arrow pointing to the large receptive fields away from the fovea, and the foveal small receptive fields in amblyopia probably are no longer small. So they may see a gray patch no matter where they look, if you can get them to fixate. So what happens with these cells in the geniculate? Where do they go in the cortex, and what's going on back there? And this is also very interesting from an amblyopia perspective. Axons from the cell bodies in the geniculate terminate in layer 4C of the primary visual cortex. So visual information from the geniculate, which we just went over, ends up side by side in the primary visual cortex, which is V1 in layer 4C. Again, clinically, maybe not important to remember 4C, but the concept of side by side is very important, as we will see in a minute. These are called ocular dominance columns. Now, if we do autoradiographs and then do a collage of layer 4C, and this is a little dangerous because it's tritiated proline, but these are classic experiments done by Hummel and Wiesel, who we'll come back to in a minute. Notice it looks like the stripes on a zebra. And one stripe would be right eye, left eye, right eye, left eye. This is a normal primary visual cortex. Let's take an amblyopic animal. So some of these are naturally occurring, some of these are artificial. This is the human, here's the monkey equivalent. So what happens? Well, Let's look again. Here's normal layer 4C, but let's take a look at these two patients and what probably would be going on if we looked at their layer 4C. Notice here, the zebra stripes are no longer evenly spaced, and attributed proline from the non-amblyopic eye is much better represented than the narrow stripes in the amblyopic eye. This is a very important contribution. Now, this is not visible by light microscopy. Well, what about babies who alternate or cross-fixate? And this is an infant with congenital esotropia who cross-fixates. Here's the monkey equivalent. So then we'll switch and let's now start talking about amblyopia, the subject at hand. We have our introduction finished. Most people will lump amblyopia into one of three groups. Amblyopia caused by strabismus, ametropia, or deprivation. We'll look a little at each. So how does strabismic amblyopia work? Well, no one actually knows. Is it that the object of regard for the fixating eye is here, but most of the other things in space are therefore going to be out of focus, so there's blur on the retina? Or is it the mismatch of foveal images? And I don't think that answer is clear yet. But there's something about it that incites amblyopia when your eyes are misaligned if you don't use the eye. So in general, clinically, we will treat amblyopia before we perform strabismus surgery, since if they have significant amblyopia, improving the alignment is not going to improve the amblyopia. So the general principle is optimize visual acuity first, which then optimizes the effectiveness of the surgery. The reason this guideline came about is in the old days, people would operate in strabismus to ignore the amblyopia, and the results were not good. The results are much better if you address both. In fact, you should probably address amblyopia in general before strabismus. Now, I will sometimes do them simultaneously if the patient travels from far away, and I know that they're going to follow, or reasonably sure they're going to follow, amblyopia treatment guidelines after it. Now, when things are out of focus, that causes blur in the foveal area, and this also may cause amblyopia, and does. So the treatment of ametropic or refractive amblyopia is correct the refractive error. You can see that this little boy has no complaints here. His eyes look very straight. You can also tell his head is sort of pushed in here from the highly myopic spectacle on the right. And then things were happy. This is the same day stage, but he was not happy when we put the patch on. Hopefully, he'll become more happy later as he gets better. So which is more likely to cause amblyopia? Myopia or hyperopia? Well, asymmetric myopia is less likely to cause amblyopia than asymmetric hypermetropia. Next question. How much difference is required? Well, it's unusual, but even a diopter of anisotropia can, in some children, cause amblyopia, and I've occasionally seen it with less than a diopter, although I must say that is unusual. And a reminder, as you all know, who spent time with Serinia, is cycloplegic refraction is essential in all children at the time of first examination. It also, if we put a little phenylephrine in with our cyclopentolate, we'll also be getting a little wider dilated exam to look for retinal pathology. I'm not sure what you use in Thailand, but we typically here in the United States will use a blend of 1% cyclopentolate or 0.5% cyclopentolate and 2.5% phenylephrine. Our pharmacy compounds it here and mixes them. Normally we would use a drop separately. In some parts of the world with very dark eyes, it is important to use atropine, and you have pretty dark eyes in Thailand, so there may be a time to do an occasional atropine refraction. If that's done, and that's the gold standard, that's usually instilled 1 drop of atropine in each eye for 3 days, at least for us. Now, you can have bilateral amblyopia. This is a little girl with high hypermetropia, and she typically it'll be over 5 diopters. This, if the visual acuity is equal, we would not patch or penalize. We would simply correct with glasses. And as an adult, her best corrected vision may, when we first see her, start out poor. But if it remains this without improvement, it will improve, but typically it'll go to maybe 20/30, 20/40, maybe 20/25, but just a little less than perfect with this form of amblyopia, depending on when you start the glasses. The note photo screening devices, which are used in pediatricians' office in our country, are changing the time at which we diagnose anisometropic amblyopia. Sometimes they don't work as well when the hypermetropia is equal. You can also develop meridional amblyopia, and this is the example here. It can be predominantly vertical or horizontal. It's usually when there's significant astigmatism, and therefore the letter presentations, and in the Thai letters or our letters, you may find that certain letters that are vertically oriented are seen better in this particular patient than the ones that are horizontally oriented. Now, the most severe form of amblyopia is stimulus deprivation. So what we have here is a cloudy lens, and there's no formed images on fovea. So there's no high spatial frequency retinal images. What can cause this? There are many causes, and you know these, and I know them. Ptosis, corneal opacities, cataracts, even persisting vitreous hemorrhages, media opacities, sometimes iatrogenic. We can cause it with too much patching. Let's take a quick look at these three patients. This little guy, a girl, has a capillary hemangioma. The capillary hemangioma did very well, but the amblyopia did not do so well. It was pretty profound by the time we got the eyelid to shrink. This is one of my patients with a PFV or PHPV cataract. You can see the little blood vessel running out here, and there's a very subtle stalk back here to this. And this is a corneal opacity. I believe this was a Peters anomaly patient. There's many, many other things. And these are very severe forms of amblyopia. These need to be treated very early. We usually remove visually significant congenital cataracts somewhere between 4 and 8 weeks. We tend not to remove them like I used to do in the first month because there may be a higher risk of glaucoma, but you'd like to get there right, hopefully before about 8 weeks of age. So there really is a fairly small window. Now, if we see a child at 6 months of age, we'll still operate on the cataracts, but I'm very concerned that the amblyopia might be quite profound. So you want to treat the amblyopia properly, initiate appropriate occlusion or penalization or some other technique. But there are things that mimic amblyopia. This, I chose an obvious example. This is optic nerve hypoplasia. The double ring sign is shown here. What looks like the cup is actually the entire disc. This is a very small optic nerve. But when these are subtle, I've missed them on numerous occasions, and you can have other subtle things affecting the retina, other problems that may cause amblyopia. So when we see such a patient with an organic disorder, we are quite sure they will also have amblyopia. And clinically, we'd love to know, but it's sometimes very difficult to tell, is a reduction in vision 40% organic and 60% amblyopia or some other ratio? And we will take things that look like they're not going to get better and very cautiously do occlusion in infants. For example, a toxoplasmosis scar that is at the macula may be adjacent to the macula, and sometimes it's surprising how good the visual acuity can be when clinically you look and say, oh, that scar is right in the macula, maybe right on the edge. So in those patients and others, we will often cautiously patch, but we have to be very careful we don't cause amblyopia in the good eye. Now let's talk about treatment. So we have to go way back in time to before the year 900, when amblyopia was probably first described. It took the Europeans, the Pharynx, many centuries to catch up. And here's Leclerc, who apparently had strabismus and amblyopia, but this diagram does not, this drawing does not look like he has strabismus. These are the two people whose names I mentioned earlier. There are many, many more contributors, but Hubel and Wiesel did the seminal work for which they received the Nobel Prize in 1981. And this book is rather long, but it's their kind of description of their work. And it's a very interesting story if you look in Science in about 1981, when they described their discovery, their seminal discoveries, which were actually in some part accidental, as so many interesting things are in life. So what are our principles of amblyopia treatment? Well, we want to correct visually significant structural abnormalities, as we've talked about, correct the refractive error, and in some way encourage the brain to use the amblyopic eye, usually by using occlusion, penalization, or other techniques. This is the baby I showed you earlier. This is a different baby where we're removing the cataract. This we're using an anterior approach. You can also do posterior approaches. And most of the surgery we do is done by manually here with vitrectomy instruments. So we really haven't done our job when we do the surgery. We haven't done our job until we do this. So this is the same day. This is the child when the glasses first were put on, screaming, very unhappy, and all of a sudden she opened her eyes a couple of seconds later. She's looking around the room, her mother's crying. She's very aware of the world when she wasn't a few minutes before that. So these can be very dramatic. We do sometimes use aphakic contact lenses, but you have to watch for mistakes. So it's called Murphy's Law. What can go wrong will go wrong. It runs rampant all over the world. And this is a family who thought if a little is good, more must be better. So the child is wearing her aphakic contact lenses, but in addition, she's wearing aphakic glasses. So the total correction here, as I recall, is up around 50 diopters, which is way over the 25 to 30 we were supposed to be using. These are one of the commercially available patches. There's many different brands. Again, our patients may not be happy at first, but hopefully are happier when the vision improves, as this little guy did. How much occlusion should we do? So what I was taught and what you're being taught, there's different. Typically today we'll do it as number of hours or what is really percent of waking hours. In patching, I tell the parents will change over time. It commonly will be done for the first decade of your child's life, maybe longer, maybe less. We may do 1 hour to 6 hours a day, and also numbers in between, 1, 2, 3, 4, or 6 would be common answer. However, be very careful with very young infants and even young children because their number of waking hours is small. So 6 hours a day in a newborn may be all day patching, or that wouldn't be true in a 6-year-old. And I was taught to use all-day occlusion. We don't do that often anymore. It does prevent binocular interaction, and it's very easy to induce sometimes severe occlusion amblyopia in the good eye. So the basic rule, if you're going to patch all day, is generally see the child back 1 week per year of life. So a 4-year-old would be seen every 4 weeks if you're doing all-day occlusion. A 1-year-old might be seen weekly or close to that. You can improvise patches as shown here. You just have to be sure there are no peek holes. And then we'll sometimes turn a contact lens around and use it for occlusion. The kids, I worry about this for a couple of reasons. These tend to be severe non-compliant cases. You're putting the contact lens on what may be the only good seeing eye because this is probably going to be severe amblyopia if you've resorted to this type of technique. And the kids generally quickly learn to push the contact lens under the eyelids and get it out of the way. So it doesn't always work, but it's sometimes useful. We also have problems with skin irritation. In one of the hospitals I was in, we had a wonderful colostomy department. So we would send some of the amblyopic kids with bad rashes down to the colostomy department who are experts in dealing with rashes. We just had to be a little careful with the medications they might choose. And then the question here is, what's wrong with this picture? Well, let's look. We have a pretty straight eye. This one is deviating in, and there's a rash here. Is it possible that I told the parents to put the patch on the wrong eye, or the parents misunderstood me, or maybe the amblyopia has reversed? In either case, this we need to find out why. So the rash is on the wrong eye. Now, you can use this kind of patch, but you have to be careful for 2 reasons. The most important one is the kids tend to peek. The second one is, I think there were 2 kids over the years who had corneal abrasions from these, but that's pretty uncommon. These are type of patches are wonderful, but only if the compliance is good on both the part of the family and the child. So I typically will start to use this if the child is getting better and is compliant with the occlusive patch. And then compliance all around the world is a problem. Here we're resorting to some older techniques. This was Dr. Parks's patient. This is one of my patients. And you may be familiar with duct tape. There are books written about this type of tape. The parents ended up using it. They let me take the picture, or they sent me the picture, but I had to promise I wouldn't tell who they were, so they weren't accused of child abuse, which they definitely were not. And then we get to some draconian measures. These are two of my patients. These are removable splints that would go on when the patch went on. And this little girl was an escape artist. This was a removable jacket, but she would even get out of this. And her mother was trying very hard to do the occlusion. One of my orthoptists in Boston came up with the Patching Hall of Fame, which is shown here. And the kids would try hard, the older kids, to be on the Hall of Fame wall. Now, in the United States today, we might not put the names on the bottom, but nevertheless, it worked very well. Let's change and talk about penalization. This is an alternative to occlusion, typically used for mild to moderate amblyopia, but does not tend to work as well for severe amblyopia. And there's two basic techniques. You should be familiar with both. One is pharmacologic, the other is optical. Pharmacologic penalization can use almost any parasympatholytic agent, but atropine is sort of the gold standard. And it's generally one drop in the good eye, either once daily, twice a week, once a week. And we started out doing it once daily and then moved to less often. This was around years ago and kind of fell into disuse. I believe it was David Guyton in Baltimore who kind of reinitiated its use. And now it's part of our standard practice. I do worry a little bit with this in South Florida and maybe Thailand. It makes the pupil big and lets more UV light in. There are other ways. So we could optically defocus. This is the same patient, but we'll pretend like we're doing this on purpose. And then something called Bangerter foils, tape, and others. Bangerter foils are quite popular in some cities. We don't use these much in Miami, but I believe they're made in Switzerland and they're graded. So they're a cloudy foil that sticks on the glasses and very useful and work very nicely. And you can select these optical density and kind of tune them so that you allow some vision, but you make the vision in the good eye a little worse than the amblyopic eye. You have a choice of how dense the occlusion is. And this is put on glasses. You can also do this with frosted tape, although you can't control the density of it. But this is just standard commercial tape. Now, the most fun part is what's new. Let's talk about it. Acupuncture, strange. Pharmacologic agents, systemically. Liquid crystal glasses, we're going to talk about all of these. And then I want to make you very familiar with changes in our understanding of the mechanisms, a little different from what I just taught you, and especially the amblyopia treatment studies, which you really should know. I have a couple slides for that. So the amblyopia treatment studies were a series of multi-center studies, which we participated in here, and they're proposed by a group called the Pediatric Eye Disease Investigator Group, which is mostly North Americans, Canadian, USA. There may be one European in there or two. And then these, we hope, are funded by the National Eye Institute. So that's the process. If we take the 50 or so studies that were published and distill them and take what I think are the major 8 points, here they are. Number one, atropine can work as well as the patch for moderate amblyopia. And if you go way down to the bottom, moderate amblyopia is 20/40 to 20/80. In the earlier studies, it was actually 2100 or worse, but the definition was changed. Severe amblyopia is, for the sake of most of these studies, 2100 or less. So patching 2 hours a day works as well as 6 hours a day for moderate amblyopia. I was taught to patch full-time for severe amblyopia, but it turns out that 6 hours a day probably works almost as well. Maybe it's slightly slower, but it does have less risk of causing amblyopia in the good eye and blocking binocular interaction. As I mentioned a few moments ago, atropine once a week may be as good as once a day. And item 5 here is very important. If you're treating amblyopia in children and they're still in the amblyogenic age group, let's say that's up to about age 8, there is up to a 24% risk of recurrent amblyopia when you stop the treatment, when you think you've successfully completed treatment at age 4. So be very cautious if you successfully and gloriously treat a 4-year-old and then say, oh, we don't need to do any occlusion anymore. Just continue to watch them to be sure that the amblyopia does not come back, because it may. And you don't always need to patch. If you have a new patient who has amblyopia, particularly in the moderate amblyopia, if they have moderate anisometropia, you can sometimes do glasses alone for about 3 months. And if the acuity gets better, keep doing that. If it doesn't improve, then you may want to add occlusion or penalization. And as I mentioned earlier, I was taught amblyopia treatment doesn't work after age 9. That's not true. There may be things going on in adults, as we'll discuss in a few moments. And then there's a theory of binocular treatment useful for amblyopia, which we'll look at. So let's look at acupuncture first. I don't think this is persistent, but this is one of my patients. Very sharp parents called me and said, you know, this article just came out, and they had seen it actually before I had. This was back in 2012. So I said, let me call you back. So I read it, called him back, and I said, let's do the following. If you want to try this, pick a good acupuncturist and send me a couple of pictures. Why don't you keep doing the occlusion and try the acupuncture? They did it for about 3 or 4 months and then finally abandoned it. However, this has probably not withstood the test of time, but it is in a peer-reviewed journal and may have a role in some practices. In fact, if any of you use it, please email me, because I have, other than this one patient, no experience. But I think it's yet to be established. Now, drugs have been used. And this goes way back to the first publication in 1990. And the drugs that were used tended to be Parkinson disease type drugs, levodopa or levocarbidopa. And this went on for quite a long time until 2015, when a randomized trial was published which showed that the levodopa did not improve the visual acuity. And so this has generally been abandoned. We don't do it. I'm not aware of anyone in this country who does. You may find it, but stay tuned, because there'll be other agents in the future that might play a role in the pharmacologic treatment of amblyopia. So this is something that came out about 2 years ago, and this looked fabulous. Now you have to be careful, because the development office, this is sort of the public affairs group, said this. But the real thing is these were not humans, these were adult mice. However, ketamine seemed to offer some improvement in mice. So here's another pharmacologic agent that's being worked on, and there'll be more things to come. Also, ketamine may reactivate the visual plasticity in adults. And that's, again, our mice. That's the article that I just showed you. So what about these? Some of these are on the market, some are off. I again have no financial interest in any of this, but these were clever little liquid crystal glasses, which go way back to the 90s. And these are a couple of brands. I think they may be off the market, but this is something that you can set them to occlude. You can see how this eye is dark on this eye child. These are electronically driven, again, liquid crystal, and you can set them for half hour, hour. You can even set them to flicker. So there was a study done, and they certainly know better than patching or penalization, but it was roughly equivalent for moderate amblyopia. So there may be a role for this. They're expensive, but they may work. Not for severe amblyopia, probably. Now, what's terribly interesting is these new concepts. So is it possible to treat amblyopia in adults? And by implication, yes, it is. Let's find out if we can do this. So it's been known for a long time that pulsating magnetic fields, so this is called repetitive transcranial magnetic stimulation. Its acronym is here. Pulsating magnetic fields can either stimulate or suppress neurons, and they can be focused to a degree. And depending on the frequency, you might be able to selectively augment the activity in certain portions of the brain, particularly for us, the primary visual cortex. Does it work? We don't know. Studies are in progress, but very interesting. The original concept of amblyopia was sort of disuse. The concept that came about during the time of Hubel and Wiesel to the present time is competition, but much more recently, binocular interaction has been described as a possible cause or a possible factor in amblyopia. And there's some references listed on your slides. So in this treatment model, images are presented to both eyes with high contrast images presented to the amblyopic eye and low contrast images to the normal eye. Let's look at a couple of examples. This was a multi-center randomized trial that we participated in through the Pediatric Eye Disease Investigator Group, but we used an old game that looked very much like Tetris. And the kids were randomly assigned to either patch or the game. Well, the results were inferior. And there may be some reasons. Part of it could be the design of the study, and the kids just weren't that interested in the game. So another study was published in the same month. This is back in December of 16, which is an action-oriented video game called Dig Rush. Now, notice this. This is there's a score. You can win, you can lose. This is much, much more interesting to kids at the present time. And so one eye will see these figures, the other eye will see these figures. Conclusion, this was equally effective. So who is right, this study or this study? Well, I think we're still studying this. So Dig Rush, for those of you who are gamers, is made by Ubisoft. Ubisoft makes some other things, which includes Assassin's Creed. So this is what you might want your 3-year-old or 4-year-old to do. This you might not want your 4-year-old to be doing. So in conclusion, amblyopia has a very rich history. Clinical observations that have been made over 1,000 years are supported by discoveries in the laboratory over the last 70 years or so. And new concepts are challenging conventional thinking with respect to the mechanisms causing amblyopia as well as the treatment. Very exciting time. So we go from this to this to this, and who knows what's next. Thank you very, very much for your attention. And as I close this, I'll just put on the amblyopia treatment slide again, the study slide, because these are important conclusions for you. Thank you. Serenia, are you there?
Yes, I'm still
Oh,
here.
fantastic. Good. I'm glad.
Okay.
Are there any questions? Let's see if I can get the screen going back on.
Yes, for the residents, do you have any question for Dr. McEwen? So I will start with my first question. After you treat the amblyopia and it get better, so how do you wean off patching or?
Good
Like
question. So our question is, how do we slow down? So we aggressively treat, let's say we start at 6 hours a day, things are much better. The starting vision hypothetically we'll say is 2100, and we're now down to 2025, or we're down at 2030. We might go from 6 to 4 to 2 to 1. And then my two colleagues and I differ here, as Serenia knows. I will typically continue to patch for very long periods of time, doing some token or small amount, maybe even a half hour a day, purely to reduce the likelihood of recurrence. The reason I started doing that many years ago was I have a strong sort of far away practice when people come from other areas, and they don't always come back for follow-up at exactly the right time. So what I found is we were going through these oscillations of good vision, bad vision, 6 months later, good, bad. And I finally thought, well, maybe if I just do some very low level maintenance occlusion, is what most people call it, that we may help reduce the likelihood of recurrences. So I will even patch beyond when the vision is almost equal. My two colleagues, I don't think do that. Rules are, you should be able to stop, but as long as you follow closely, you'll be okay. And again, most of us will taper. If we're starting at 6, 4, 2 to 3, 1, 0. Any other questions?
I have a further question on the
Yes.
maintenance of the occlusion. So if you already achieve the same vision in both eyes, and now you're just patching for maintenance, how long do you patch?
Yeah. So good question. I will typically, again, go down to something about a half hour to an hour. A half hour might be homeopathic. It may do nothing, but it makes me feel better. But I will typically do small amounts, somewhere in the range of a half hour to 1 to sometimes 2 hours for maintenance during that period when they're susceptible to recurrence. Good question.
Thank you. I have one more question, and it's
Yes.
quite specific. We've been treating this patient of she had congenital cataracts in one eye, and she was treated with intraocular lens since she was young. But and she has been lost to follow-up for a few years. And when she got back, she was about 9 years old, and the vision in that eye is about counting fingers, I think. And so we did an IO exchange for her, and now her vision is about 636. So that's like 20.
Oh,
120.
2200.
Yeah,
Yeah,
20.
636. Yeah. Okay,
Yeah.
good. Yes. Pardon me,
She's
yes.
about 9 years old now, and the other eye is 2020. So she's like above the amblyopic age now. And so how long do you recommend the patching, or
Well,
if at all?
that is actually also a good and very practical question because that comes up frequently, unfortunately. What I will typically do is if we've lost a child to follow-up, done the proper steps optically, and the visual acuity is poor, but the child is 9 years old, I will oftentimes talk to the family and say, 20 years ago, I would not have tried. Today, I'd recommend you go ahead and try. And I, for that, would probably not use atropine, but would consider occlusion. And I will tell them our goal is perhaps 6 hours a day for 6 to 12 months. That may be an impossible goal. 4 is better than 2, is better than 0. Even 1 is better than 0. And I will say, do something. See if you can do some patching, and you can divide it into small segments. So let's say our goal is 6 hours a day. You could do it in 3 2-hour segments. And many children cannot get to that level. So of patching, but any patching is better than none. And I tell the parents, when your child is 20 years old and we look back on this, we want to know we did the right things and they either worked or didn't work or worked partially. And I think it's worth the effort. Serenia, do you agree with that?
Yes, doctor.
Okay, yeah, I think that's what I would do at age 9. Even at age 12, I'll still talk to them about doing it. Now, from a practical standpoint, the kids are at an age where they're in school. It's very, very hard to get these things done. Sometimes you can build in a reward of a video game while the patch is in place, but I think it's worth trying.
So what time do you recommend the patching? Because like she's in school and she said she can't see
Yes.
with that
Good
eye.
question. From a very practical standpoint, I say, well, what do you do at breakfast? You all have breakfast together. So what I will say is, why don't you put the patch on the moment the child wakes up through breakfast? And if you take them to school, or you can take the patch off the moment they come in the door at school or get to the front door so they're not embarrassed with their friends. So that may get an hour or two, depending on the child's schedule. And then you can try again when they get home at night. You might say, okay, this is relaxation time. We're going to watch a movie or something, but you have to wear the patch to see the movie. So in those sort of tricky ways, you can sometimes get it to work. What I tend not to do is delegate the patching to the school, because the teachers are busy. They don't have time to watch this, and the kids will immediately have the patch off. But that's very practical, and you just have to tailor it to the family and their sort of unique standards. And sometimes you can do more patching on the weekend than during the week, although most of the kids would like to have the weekend free, and the parents as well, but that's a time where you can give them a little extra patching perhaps also.
Thank you, Professor.
Yes, happy. So Serenia, I think I better go off to my clinic. They're calling for me. This has been a great pleasure. Let's do it again sometime. If you could, Serenia, please send me the roster of the new roster when it comes out with your new house staff, so I know who everyone is. And again, if any of you or know of anyone in Thailand, we have had such wonderful experiences with our Thai scholars. Please contact, if you're interested in anterior segment, Dr. O'Brien or me, or any of a number of people around the country. My colleagues there know who's good and who's interested in teaching in our country. Thank you very much for having me back. I look forward to coming again.
Doctor, before
Yes.
we end the meeting, two of our residents are interested to maybe visit you at Bascom Palmer.
Oh,
Do you think it's okay as an observer for a few weeks, maybe?
yes, that we can do too. And I didn't mention that. Yes,
Yes,
Sarinya. Thank you.
So
'Cause we
maybe
have had,
Kwan and Woon can say hi to Dr. McQueen if you're interested to visit him at Bascom Palmer.
and we would love it. Mhm.
Yes.
Thank
Thank
you
you
very
very much.
Now, please email me, and then I will direct you to another administrative office that Sarinya knows about, and they will coordinate the observership. I think we're turned back on. It all depends on COVID, but we're coming back online. We don't have any observers right now, but very soon this will be back working again. And that's another alternative. Instead of spending a full year with us, as Sarinya did, you can spend just a couple of weeks or a couple of months with us, I think up to 2 to 3 months. And we love that. We love to have our international visitors.
Okay,
Thank you again for inviting me.
Yeah, so maybe we
Sarinya.
have Vince Kanawi, who is the moderator today, but he doesn't have any chance to speak now. Maybe Vince, if you want to speak something to Dr. McQueen, please.
Oh, I just in on behalf of all the residents, I would like to thank you again for coming and teaching us today. I think we have learned many new stuff today, and I think it's wonderful lecture where you teach us like from the very basics into the clinical settings, and then sum up with the ATS summary. And I think you give us a chance to ask questions as well. So I would like to thank for that, and thank you, Ajahn Srinya, for organizing this event as well. Thank you, Dr. Srinya, and thank you, Dr. Greg, so much.
Thank you all. My
Thank
pleasure.
you for spending time with us. Bye bye. See you soon.
Goodbye.
Bye, everyone.
Bye-bye.
Okay.